again, good evening, everyone. My name is Njoki Wachira, and I work for Equalize Health. I want to welcome you again to the 9th session of this COGS tele-mentoring series on strengthening obstetrics and gynecological care for maternity teams. Today's topic is on maternal collapse. Equalize Health has partnered with COGS to bring you this online series. We are currently implementing several tele-mentoring programs in health professionals in India and in Africa. So before we begin, let's start with some little housekeeping announcements. Please keep yourself muted unless you're talking. If you can, please put on your videos. Please respond to questions without any hesitation. We are here to all learn from each other. You can also post your questions on the chat box. So I'd like to welcome Dr. Kigondu to introduce our speaker for today.
Thank you. Thank you very much. Am I audible?
Yes, you are.
Thank you. Today, all the way from the United Kingdom, I would like to introduce Dr. Francis Ghidai Muriithi, who is an alumni of the Medical School of University of Nairobi as an undergraduate, and he did his obstetrics and gynecology at the Aga Khan University. He has continued to further his studies. He did an MSc in evidence-based medicine at the Oxford and is a member of the Royal College of Gynecologists of the UK. He has rich experience in various practice settings across both Africa and the United Kingdom. He is passionate about translating evidence-based medicine into practice. He acquired this passion while he was at Oxford, Academic Health Science Fellow in evidence-based healthcare. His current research interest is reducing preventable causes of maternal deaths in both Africa and in South Asia, which is the reason why we are having this tele-mentoring series to empower people with knowledge so that we can be able to reduce maternal morbidity and mortality. Dr. Muriithi also supports evidence synthesis work for the multi-county e-motive project on postpartum hemorrhage and for the Where and Why Mothers Die project, within which his doctoral research is nested. He'll soon lose his doctor title and become Mr. Doctor, and he'll become Mr. So his doctoral research training fellow in Global Women's Health, which is a WHO collaborating center for global women's health in the University of Birmingham. He's also a clinical fellow at the Tommy's National Center for Recurrent Miscarriage, and he's an honorary lecturer at the University of Nairobi. And very importantly, he's the core vice chair of the Royal College of Gynecologists Global Health Trainees Committee. With that, I want to welcome Dr. Githae to take us through maternal collapse, a very, very important subject.
Thank you, Njoki, and thank you, Simon, for the kind introduction. And good evening to you all from a very cold England. It is 4 degrees, and you guys, I see you are enjoying 19 degrees in Nairobi. I'll share my screen. Able to see my slides?
They are visible.
Yes,
Thank you. I have no conflict of interest to declare, and this presentation is voluntary with no financial gains, and it's made in my personal capacity and not on behalf of any of those institutions to which I'm affiliated. So at the end of the next 1 hour, I am hoping that our interaction after our interaction, we'll be able to describe how to identify women at increased risk of maternal collapse, list the causes of maternal collapse, and then describe the initial management of maternal collapse and subsequent continuing management, and have some insight on what happens when we do not take maternal collapse seriously to both mother and the neonate or baby. The definition for maternal collapse, it's an acute event and in many cases unpredictable. But I wish to say that although it is unpredictable, it does not mean that we do not prepare for what is unpredictable. If we are ready, then whatever is unpredictable will have less impact. When maternal collapse occurs, it usually involves the cardiorespiratory system and or the brain, and it causes reduced or absent consciousness level, and it can be at any stage of pregnancy, right from the antenatal, intrapartum, postpartum, up to the 6 weeks. Now, the incidence data on maternal collapse is often unreliable and is often not usually reported. It's because what we usually report is near miss and the other extreme when mothers die. So those are the data that we have. And if you would like to know the statistics about maternal collapse, it is in between the near miss and the maternal deaths. The importance of us having this chat this evening is so that we are able to detect early, escalate, and intervene so that we can save mothers' lives. Like I said, although many of the incidences of maternal collapse are unpredictable, deterioration may be documented in observation charts. You know, the charts that we usually write our vital observations, temperature, respiratory rate, oxygen saturations, blood pressure. All those charts, all that information is very useful in us detecting patients who may then end up having maternal collapse. In fact, on the paper on the right-hand side, I was one of the co-authors who examined early warning systems in obstetrics, which is just a complicated term describing the charts that we use for monitoring women during pregnancy and after childbirth. And in that systematic review, we were able to show that obstetric early warning scores are effective in predicting severe morbidity and mortality in critically ill obstetric patients. There's a caveat there, it is in critically ill obstetric patients, because with the collapse, it can happen with any patient, not only the critically ill one, even the one you've just left walking in the ward a few minutes ago, God forbid, it can happen in that particular one. So these are charts that are modified for use in pregnancy, not the usual ones for the general population. Now, where death has occurred, the recurring theme is poor resuscitation. I was just looking at some of the data that I have just finished analyzing on determinants of maternal mortality in Africa. And indeed, the lack of adequate resuscitation has come in as a recurrent theme in about 5% of cases of mothers who die. And the other one is about monitoring of mothers. This is data that I'll share going into the new year. Now, regarding the causes of maternal collapse, if we can just concentrate our eyes on the diagram on the left-hand side, I know the ones that are most common to us are the ones that are affiliated to or linked to direct causes of maternal mortality. Beginning on the bottom left, there's hemorrhage. And the one that we know mostly is obstetric hemorrhage. But there are other unique causes of hemorrhage that we also need to be aware about. So the first one, there additional cause of hemorrhage is splenic rupture, hepatic rupture. May I just ask one person to unmute and tell us in what instances they think that splenic artery rupture or hepatic rupture can happen? I'm looking after for 2 reasons.
You can type on the chat. You can type on the chat so that we have many entries.
Please do.
Yeah, chat. You have 30 seconds.
Simon will tell us the first 3.
Yeah, trauma has been mentioned. Trauma, Joshua Juma, trauma, injury, Jacqueline Oire, trauma, following blunt abdominal trauma, trauma. I think
Fantastic.
hypertension, someone has said hypertension, yeah.
Yeah, that's good. Hypertension can happen, hepatic rupture can happen from, hypertension.
Yeah.
I like
Excellent.
trauma, but we need to qualify trauma a little bit more. Trauma can happen, for example, when there are bomb blasts. Yeah, a lot of women died or lost their babies, not from the bomb blast, but when they came to hospital and we found that their internal organ bleeds. It can happen following road traffic accidents. And a very, very important cause for us is domestic violence. So people will kick, unfortunately, women in their tummies, hoping to injure the baby or injure the women, but unfortunately end up with hepatic or splenic artery rupture. So always good to think about that. Thank you. So hemorrhage, then on the bottom right is sepsis. We know sepsis. And then we can then move on to back to the left-hand side. There's pulmonary embolism and amniotic fluid embolism. And then drugs that we use on the labor ward, things like magnesium sulfate, local anesthetic, or women who abuse drugs can also lead to maternal collapse. On the right-hand side, anaphylaxis can be to medication. The last patient I had with anaphylaxis, I think I said last time, was due to an apple that they had bought from one of the supermarkets, brought in by a relative. And then aortic dissection, rare things, but they can happen. Cardiac causes like myocardial infarctions, cardiomyopathy, arrhythmias. I say that whenever you have a woman with chest pain in pregnancy, the same way we talk of abdominal pain in pregnancy being an ectopic, please always think about chest pain in pregnancy, especially on women with high BMI. Always think of a heart attack as well. It don't just happen to the elderly men, okay? And then hypoglycemia. I don't know how hypoglycemia, of course, affecting the central nervous system and leading to collapse. And then, of course, top in the brain, eclampsia with intracranial hemorrhage is a cause. Now, there are some people who've been clever and put that onto a chart on the right-hand side. And you'll commonly hear of the 4 H's and the 4 T's of maternal collapse. The 4 H's have been summarized as hypovolemia, hypoxia, and then electrolyte abnormalities, that is the sodiums and the potassiums, hypothermia, which is less likely nowadays because we ensure patients have warm fluids and blood we are giving patients is passing through a warmer. I hope that's what you do in your centers. And then thromboembolism, among the 4 T's, toxicity, tension pneumothorax, and tamponade. Tension pneumothorax has been known to happen in some patients actually during second stage. So suddenly the patient collapses in second stage. So we have to think about these things. And if you don't have them in the back of your mind, then you may not be able to save that life. And then eclampsia and preeclampsia. I have put references on every slide so that in case you want to read the papers from which I've gotten this material for your own guidelines and your own use, please do feel free to access those references. When we talk about shock in obstetrics, it's basically 4 types, and the same causes are then listed. So the first one on the left is hypovolemia, which can be absolute, meaning that the volume has actually left the body. And that happens in things like PPH, diabetic ketoacidosis, when it's associated with things like vomiting and dehydration from things like diarrhea. And then there's relative hypovolemia, for example, after a spinal, which has a Costa block that is higher, and the patient gets hypotension. We pregnant women, when they are lying down and the pregnant uterus compresses the inferior vena cava, also leads to supine hypotension. I've mentioned cardiogenic and distributive shock and obstructive shock. The 3 on the right-hand side, the fluid is still in the body, but the way it moves between the body's compartments, the vessels, and the way it moves around the body, the heart, pumping it, has been affected in one way or another. Now, it's always good to remind ourselves about the physiological changes of pregnancy, because while they do pregnancy good, they also impact on resuscitation. I'd like you to focus on the box on the right-hand side. Top there is the cardiovascular system. It does increase by up to 50%. Unfortunately, that leads to dilution or anemia. and reduced oxygen carrying capacity, which may affect the resuscitation. The heart rate is usually up by 15 to 20, and then that does increase cardiopulmonary resuscitation circulation demands, and the same thing applies to the cardiac output. In terms of uterine blood flow, it's usually 10% of the cardiac output at term. If I'm not wrong, it's about 5.5 liters per minute. So you can see why women who bleed following childbirth can easily bleed the whole of their blood volume within minutes, few minutes. So that's important, and especially when you think about replacing their volume. Systemic vascular resistance is reduced, and what that means is that sometimes the blood will be settling in the lower limbs. That's why sometimes we elevate the limbs. Decreased by 10 to 15% is the arterial blood pressure. That decreases the reserve, and I've mentioned about the venous return. Now, respiratory rate, the respiratory system, there's a summary there of how it is affected. I'll move down to gastric motility, and you see that due to relaxation of the lower esophagus and decreased gastric motility, women who collapse are at risk of aspiration. Yep, and the uterus is enlarged. We've mentioned about it compressing the inferior vena cava. Their weight increases, and the large breast tissue may interfere with intubation and make ventilation more difficult. There's another one that is typically very important in African moms, the ones who they make their hair and they put a mound of it on top of the head. And you can imagine trying to intubate such a patient who has a mound of hair on the back of their head. So that's another one to think about. In such situations, maybe worth just getting rid of the mound of hair in the interest of their life. Now, when a woman collapses, it's similar to other first principles of approach. And we talk about the standard approach of A, B, C, D, E. In the chat, maybe you guys can type what A, B, C, D, E means. Simon, are you still there?
Yes, in 30 seconds, in 30 seconds, let them type. Airway, I've seen Lydia Minyenga. Breathing, Lydia Minyenga. Geoffrey Mochui, airway. E. Circulation, John, Brenda, circulation. Joshua, airway. Airway, Agnes, circulation, airway. Breathing, circulation. D, what did they say D there? Let me see. They're coming in thick and thin. Drugs, I'm seeing drugs. I'm seeing drugs, breathing. Disability, there is disability.
That's the right
also.
one, yeah. Mm-hmm.
Excellent, excellent.
There's no
I think there is exposure.
Fantastic. I think you've covered all of them. We'll see them.
Yeah.
Now, I just want to say that in terms of maternal collapse, your interest is saving the mother first. The baby is secondary. I don't want to be mean to the baby, but it's saving the mother's life first. That's the priority. And everything you do is aimed at saving the mother first. You've got all the full things about the standard approach. So the primary survey and resuscitation, it's aimed at identifying life-threatening problems and deal with them as you identify them. You don't wait for the end. For example, you find the airway is compromised. You probably want to make sure it's open and secure it, and then ensure that the patient is breathing and the ventilations are adequate. If they are not, then you may need to give them supplementary oxygen or breathe for them initially, maybe by bag and mask. We've talked about circulation, ensure that the patient has a good enough IV access, 16 gauge. Now, this is another assignment that I'm going to give the group, and we'll come back to it. Please, you know, there are different colors of cannulas, yeah? I want somebody to use their phone and check the internet, the flow rate. I'm after the flow rate. How many mils per minute does each of the cannulas we have flow? The first one is orange. Please check orange cannula. What is the flow rate? The second one is the gray cannula. The third one is the green cannula. The fourth one is the blue cannula. And the last one is the pink cannula. Please, I'm going to come back to this at the end. So guys, please do this homework. Look on the internet, on your phones, what is the flow rate for every color of cannula. So you can say flow rate, orange cannula, then you type in the chat box. So I've mentioned orange, gray, green, blue, and pink. And then you'll understand, we'll chat about it at the end. Okay, then disability and neurological status. This is where you check the eyes and do a quick neurological exam. And if the patient is having a compromised neurological status, the GCS is low, you might want to think about involving anesthetics and intubation and all that. Then exposure is where you expose the patient completely. You do a head to toe and you do a front and back examination. And as you expose the patient, please remember to cover the areas you've seen because of hypothermia. Like for me, I'm here, it's 4 degrees centigrade. Then the baby comes in and you want to assess whether there's a fetal heart. You may want to deliver in maternal interest, especially if you have to resuscitate the mom. I mentioned the secondary survey, which is top to toe and back to front. And then once you have identified the cause, you want to do the specific management. And of course, continuous reevaluation is very important. I've moved on to specific conditions. And the first one is cardiac arrest. Now, this data that I have are from my settings. They're not from your settings. I hope soon as I get more into these topics, I'll be able to give some data. Now, cardiac arrest is about 1 in 30,000, but like I said, it might be higher in your settings. And the initial management for all collapses will be A, B, C, D, E. Now, depending on where you are, when we think about collapse, we think about community setting and the hospital setting. In the community setting, you want to initiate basic life support. In the hospital life setting, you want to initiate advanced life support. Now, within the hospital compound, you might also be in a situation where it's actually a community setting within the hospital, like it's in a corridor, it's in a clinic, or it's a mother who is in labor and you've told them, latent labor, you've told them you walk around and then come back. So, and then they collapse in the compound. So all you might be able to do initially is basic life support as you call for help and then initiate the advanced life support. Yep. Now, about cardiac arrest, of course, is to ensure that you're safe. Basic life support, we are told to start by checking whether the woman is responsive. So you shake her, you shout her name or whichever other way you can get her attention. If there's no response, you need to call for help. Using the systems you have, it might be just shouting, but I do hope that with time, hospitals have put in emergency buzzer systems. Like all I need to do is say, please do the code red. Code red would mean somebody moving onto the phone and dialing 2222, and then the operator will put a call out to everybody in the cardiac arrest team to come with information as to where the event has happened. Even the community, you can use the ambulance system 999. I'm not sure about your setting, but for example, where I am, if there's an emergency, I'm assured that there will be an ambulance within 7 to 8 minutes. I do hope that some of our systems are aspiring to improving towards that kind of situation. Then, of course, if you've called for help and you are the only one, you go back to a woman and start CPR immediately, cardiopulmonary resuscitation. Now, you may not be able to go for the airway if you are alone. Then if that's the case and you're in the community, it's said you just go for the chest compressions. However, if you are 2 of you, or you're able to interchange giving 2 breaths and the compressions, then please do so. Remember, pregnant women are best resuscitated at a 15 to 30 degree tilt. If you're not able to do that, have somebody manually tilt the uterus to the left-hand side. And then once you're in the clinical setting, you can use drugs and defibrillation as per the adult guidelines. The idea of having a cardiac arrest team in a hospital is that you'll have a physician, you'll have an anesthetist, you'll have the obstetrician, midwives, pediatricians, everybody who is required, and they will be able to give their input towards this patient. We may not remember those medicines, but somebody who is in a physician or ED, they may be able to remember. Or having these charts all over the clinical areas, that might also be helpful. or on things like crash cuts that are in our units. Remember, if a woman was in the intrapartum stage, you remove the electronic fetal monitoring before doing defibrillation, and the pads in pregnancy might be anterior posterior position due to the breast tissue. Now, this is an important thing to consider, the perimortem cesarean section. Now, we are doing a perimortem cesarean section not to save the baby. That's not the aim. If the baby is saved, it's a bonus. We say thank you. But the essence of doing a perimortem cesarean section is in a mother who has collapsed, and you need to improve her circulation to give her the best chance of survival. And you consider doing this if the uterus is approaching or above the umbilicus, and if there's no response from the mom within 4 minutes of doing a cardiopulmonary resuscitation, because in another 2 minutes, you might have and end up with hypoxic brain damage. You shouldn't say that you want to transfer the woman to the theater to be able to do this. That is wasting time. You should be at the site of collapse, and the cardiopulmonary resuscitation should continue concurrently. The aim of delivering the baby is to reduce outer caval compression, to improve resuscitation, reduce oxygen consumption, increase venous return, and make ventilation easier. All you need is a scalpel and cord clamps, and they should always be part of the emergency trolley. Women don't bleed much because their circulation is stopped anyway for the last 4 minutes. So you make an incision, whatever you are confident with, be it a Fan and Steel or a Joel Cohen or a midline one, whichever you're confident with. Closure is not required immediately because the bleeding is minimal. And once resuscitation is successful, you transfer the patient to the theater to assess any damage you may have caused in the course of trying to deliver the baby and to complete the operation. If, sadly, it is unsuccessful, then you need to discuss with the coroner or the pathologist. These are in our case, it's the coroner. For your case, it might be the pathologist. And remember, please, any mother who dies, don't remove the lines that had been put for IV access, because the pathologist will be looking at this to say, to judge whether the patient had any adequate resuscitation, or did they have the lines in place. And this might be the only medical legal thing now that we are being sued that may be in the defense of the team. Amniotic fluid embolism, another interesting one. And it's rare, survival is up to 80%. And we know it happens with advancing maternal age, where there's a lot of water around the baby, where labor is induced, where you're doing operative delivery, commonly cesarean section, uterine ruptures, and placenta abruption. So what happens is that the amniotic fluid and its particles suddenly find their way into the maternal system, and there's a sudden collapse with acute hypotension and respiratory distress and acute hypoxia in labor, and commonly it's within 30 minutes of delivery. If not addressed, it will go on to pulmonary hypertension, left ventricular failure, arrhythmias, pulmonary edema in that sequence, all the way to coagulopathy, hemorrhage, and death. The key to this is involving your seniors early, because as you can see, it might be a cascade. So calling for help and calling the right kind of help. When we think about toxicity, the common drugs we use, of course, there's antibiotics, then there's things like magnesium sulfate and local anesthetic. Magnesium sulfate antidote we know is calcium gluconate, so make sure that your labor wards have calcium gluconate, 10 mils of 10%, and that's what you give when there's toxicity. Now, local anesthetic toxicity might be as simple as when you're doing a repair of the episiotomy or a tear, or giving a pudendal block so that you're able to do an instrumental delivery. And the patient will commonly say, oh, I have this metallic taste in my mouth, I'm feeling numb around the mouth or tongue. And if in extreme situations, they may be confused or having hallucinations. In the chat, can somebody write what is the antidote for local anesthetic lignocaine? How do you treat it? And Simon, please do the honors of reading to me the answer.
That one looks hard. No one has answered.
I talked about it last time. Simon, you were in the talk last time. Do I put you on the spot or do I just give the answer?
These are different cohorts.
Fine. Okay. So I want to talk to you about something called intralipid, lipid rescue. So
yeah, Nelson has actually said intralipid. Nelson Tarus.
Well done, Tarus. Well done. Thank you. So this is the magic that will rescue you in case of local anesthetic toxicity. So what you need to do is to stop infiltrating as soon as the patient tells you they are having these symptoms, and you start the lipid rescue therapy. Commonly, the anesthetists know where these things are. They keep them locked up in a cupboard somewhere. So please ask your anesthetist where the intralipid is on your labor ward. And you'll have a copy of this presentation. You can always print out this and put it in clinical areas, the chart on the right-hand side. And basically it's just starting, it's a small bag of lipid stuff. And what it does, it mops up the local anesthetic from the blood system and binds it. And therefore it doesn't leave the blood system to go and cause damage elsewhere. Especially the nervous system where it can cause the greatest damage. So please, one of your assignments is to ask your anesthetist where the intralipid is on your labor wards. Then of course there's anaphylaxis, the common thing we call allergy. So anaphylaxis, it can be to medication, it can be to food, it can be to animals, anything can cause an allergy. And the usual principles are A, B, C, D, E, like we talked, and then removing the trigger or stopping the trigger. Lay the patient flat with the legs raised. Remember that you have to ask yourself, what is the likely cause of this collapse? And anaphylaxis, the blood volume is still in the body, but it's been redistributed and commonly in the lower limbs because of venous vasodilatation. And then you give medications that are known to be life-saving for anaphylaxis, that is adrenaline, chlorpheniramine, and hydrocortisone. And of course, high-flow oxygen. IV crystalloids can be given. There's a note here that sometimes colloids that we may think are better can be a trigger for anaphylaxis, so be careful. Patients who have allergy, known to have allergy, usually carry something called an EpiPen. EpiPen is just epinephrine. So if you get to book such patients in your clinics, please make sure that they have their EpiPens, because this might be life-saving. Now, the only way to prove whether it was an anaphylactic reaction is by doing mast cell tryptase levels at 1 hour and 24 hours. Again, some homework for you. See whether your labs can support this and ask the lab people, what sample can you pick for them in patients who have had an anaphylaxis to send to a lab for analysis. Or you pick it and preserve it in the fridge and they will come and do the serum later. Okay, there are other things that are beyond this talk, but the most important thing is to get the principles of approach to maternal collapse. Aortic dissection, acute coronary syndrome, closely related to the cardiac arrest, cardiomyopathy, intracranial hemorrhage, and venous thromboembolism are among the causes. My last case in Nairobi of maternal collapse was a case of intracranial hemorrhage. So a lady, I still remember very well, lady in second stage, we are chatting away between contractions. Suddenly she holds her head and says, this is the worst pain that she's ever felt. And then she goes quiet on us. And the next thing she starts convulsing. Of course, we thought it was eclampsia, although we didn't think she had eclampsia in the first place, but the principles say that we think about eclampsia. So we initiated the treatment for eclampsia. We did a quick kiwi delivery, vacuum delivery, and got the baby out. And we were able to resuscitate mom. She made it to the ICU. They did a CT scan and had a bleed in the brain. But unfortunately, the bleed was too much. And unfortunately, we lost the patient. So these things are a reality. What was found was that she had an aneurysm, an undiagnosed aneurysm in the brain. Now, I have put for you some algorithms, which I'll not bore you with by going through one by one. It's for you when you get the presentation. I understand it's on YouTube. You can always go through them. And this is just a maternal collapse algorithm. starting from ensuring a safe environment all the way to the end. And this has been picked from the appendixes of that guideline on maternal collapse from the Royal College of Obs and Gynae. I think it's Appendix 2. You'll find it there. You'll find a nice chart you can print for yourself if you access that article. And then there's this other one on using automated external defibrillators. I do hope that our wards, our hospital corridors, and all places have AEDs. If they don't have, please ask the governors before they go on campaigning to give us some defibrillators. Then there's, of course, the usual advanced life support. It's best if people go on courses, at least everybody in a unit from, by the way, from the person who guards at the gate, to the person who cleans the floor, to the person who makes the tea. Anybody working in a health unit should be able to provide basic life support. So please include these people in the trainings. You never know who collapses at the gate, and the person who is there is just a guard. They need to understand what to do and why it is important to someone for help. Advanced life support things maybe can be left for the clinical teams. Now, after a collapse, what do? If the patient is alive, hopefully, you continue treatment of the underlying cause and you transfer to the appropriate clinical care setting. That is the HDU or the CCU, depending on your unit. And then documentation. So please remember to document, because maternal deaths will be reviewed. They need to know what are the causes. They will need to know what you did so that they can appreciate the teams, what you didn't do. Relatives will be upset and say you killed their patients, and they will sue you. And if you document it, then that is the only thing that will be helpful for you. Then, of course, remember human beings. A lot of times we have husbands or other relatives who are on the side as all these things are happening. Please debrief them. Sometimes these things happen in clinical areas, and it's a ward or a clinical area. If there are patients there who watch the event, please debrief them. Ensure that people don't get post-traumatic stress disorder. Any staff that were involved in a process of resuscitation, irrespective of whether the outcome was good, please offer them support and debriefing. We handle these things differently, and you don't want somebody again to suffer post-traumatic stress disorder. The last thing is ensure that you report the cases. When things don't go right, the best thing we do is not to hide them. What we do is report them so that we can learn from them. And after we learn from them, then not to blame anybody, no blame, to learn from them. And then we can prevent similar things from happening next time. And it's where we get information to be able to communicate with managers and people who provide us with finances to be able to put into place measures that can prevent future loss of life. I have some resources for you. The videos which you can watch again. One is resuscitation during COVID. One is on CPR in pregnancy. There's perimortem cesarean section there. There's an GLAUM resuscitation, that's Global Library of Women's Health. And then the guideline that I've got a lot of materials from. I have some suggestions for your own preparedness. I did talk about ensuring that emergency trolleys have AEDs, and that in every shift, there's somebody who is in charge of the emergency trolley. And if it is used, there's somebody who is in charge of making sure it is restocked. It's very bad to use it and then leave it unstocked, and then another case happens and there's nothing to help the woman. Formulate emergency response teams and have regular drills, because if you don't do something regularly, then you're likely to forget. It will not be, it's like driving a car on a new road. If you drive a car on a new road, you'll be hesitant with every move you make. If it's a road you're used to, then you will not even be thinking when you're driving. It will be in your recorded automatic memory. And then invest in emergency response communication. Amongst teams is ISBA, and also having systems that ensure that teams can reach one another in the hospital. On the chat, may I have somebody comment what is ISBA? What does that stand for?
That's ISBAR.
Yes, please.
So, Gordon says introduction, situation, background assessment, recommendation.
Fantastic. I'm happy with that. Some people leave out the I and just put the SBA. I like ISBA. Now, ISBA, for example, I am on the labor ward and I need additional help. What I'll do is I'll pick up the phone. Nowadays, I orient people because you can imagine calling somebody at 3 a.m. So I call and say, I'll pretend I'm calling Kigondu. Hello, Simon. I'm on the delivery suite. We've had a case of maternal collapse and I need an extra hand in theater. It is now 3 a.m. in the morning and I'm calling because I would like you to come to hospital. So you are straight up with what you need the person to do. Either you're calling to tell them that they need to come over to the hospital immediately. Don't give them a long story. Then at the end, you're telling them I need you in the hospital. Then the other thing is, if it's not needing them, you can say, I'm calling to update you, if it's just that, or I'm calling to seek your opinion. So already their mind is set. Are they rushing out of the house or are they just giving you advice on the phone and that's it? So hello, Simon. I'm phoning you. I'm on this. It's 3 a.m. in the morning and I'm phoning you because I would like you to join me in theater for an extra hand. I'm taking a mom for a laparotomy. The situation is that we have had a lady had a cesarean section and then returned to the recovery area and she collapsed. The background is it was a cesarean section that was in second stage, rather complicated. There was extension to the side walls and we had some difficulty stopping the hemorrhage. My assessment is the patient is in shock because there is tachycardia and hypotension. And my recommendation is that we go back to theater for the laparotomy. So that should be the standard way we communicate with each other in the clinical environments. Quite often I stop people who start talking to give me stories. I just keep reminding them, ESPA, please, ESPA. I don't want to hear stories of, just tell me why you're calling me. And then knowledge and skills, it's good to, that's why we're having courses like this, to keep our knowledge and skills in place. It's good to have courses within our teams that remind us on emergency situations, be it obstetrics or general things like maternal collapse. The usual ones are very expensive, but I believe within us, we have the expertise to develop our own in-house courses and also develop certification for the same. This one I saw on the Obstetrical and Gynaecological Association site, and it's just a requirement that we need to have on our emergency trolleys. I am sure our anesthetic colleagues, if we have any of them on this talk, they will identify with this, this list. So in summary, I've been able to, I hope, I've been able to show you that prompt recognition and escalation is important in cases of maternal collapse, and effective communication is important, that you cannot manage maternal collapse alone. A multidisciplinary input is required. I've talked about structured systemic assessment. I had not talked about team leadership, but in every emergency response, there should be a leader, whether you decide whether it's a most senior person on the site or whether it's anybody who was first with the patient assuming leadership. You need to discuss within your teams, how do you respond in an emergency? I've mentioned about team debrief by starting with what went well. Remember, people do better when they are appreciated first, not when they are bashed for what they did not do. Like, we are very good at doing that. So please look at what people did well and take them through that and appreciate them. Partner and family debrief, documentation, and then reporting the incident at local, regional, and national level so that it can be captured and learned from. Thank you very much for your attention. I will move on to open discussion, but I will start with my question on the cannulas. Thank you. So do we have responses, Simon? Do you have responses? What is the flow rate of the orange cannula? Somebody can put it on the chat, please.
Yeah, the chat had quite a number of, we have a very good team and resourceful people. And they are resource rich. And I'll just go back to the beginning. There is maybe, do you have yours?
I think,
just to make sure. Orange one.
I think I can see Lydia. Lydia Minyega has summarized, but Lydia has left out the blue one. So she says, oh, sorry, Lydia. I'm in a setting where we don't assume people's gender. So you'll forgive me, but I know you're female. Forgive me, thank you. So Lydia, the orange cannula, Lydia says, flows 240 mils per minute. That is a rare cannula to find, but a lot of times if you have trauma teams in ED or in theater, they will have the orange cannula. The common one we have on delivery suite are gray cannulas and green ones. As you can see, the gray cannula has a flow rate of 180 mils per minute, and the green cannula 90 mils per minute. So the 180 mils per minute, it's possible that a half liter of fluid will go into the patient within 3.5 minutes, and a liter of fluid will go into the patient within about 6 minutes. Now, the pink cannula has 60 mils per minute. And on the end, can somebody find out the blue one, please? What's the blue one? Pink is 60. What's the blue one?
They say 36. I'm seeing Anthony there has said 36.
36 mils per minute. So this is one of the things that upsets me the most. When you go into a delivery suite and you find a patient is with a pink or a blue cannula on the delivery suite. So even those that we think will not have any risk, please, the minimum acceptable cannula, or should I say ideally, it's a gray cannula. So that's ideally the take-home message for this is a gray cannula. The other one is a green cannula. We can accept green, but please, never, ever put a pink or a blue cannula on a patient of the delivery suite. Never, ever. So, and also patients we are transferring or referring to the next facility, make sure they have 2 lines on either hand, at least 2 grays or 1 gray and 1 green. Those are some of the things that are life-saving. I just wanted to emphasize on that because sometimes people don't understand why we make a fuss on the type of cannula the patient has. That is the end of my talk. Maybe Simon can take us through the questions that have been asked. Yeah, asanteni sana. And I'm happy to answer the questions. Yeah.
Thank you very much, Dr. Githae, and I'm sure that was that has added a lot of value to the people, listeners, and I've also been able to see that our listeners are they are very educated in some of these things. Even me, those cannulas I didn't know, now I know. Maybe I go straight to the question, and maybe before that, I'll give you maybe one of my experiences in terms of splenic rupture. In the year 2000, when I was a medical officer intern, that just shows you how old I am. In the region of Machakos, the Kamba practitioners used to treat epigastric veins by pressing very hard into the epigastrium, and a lot of people used to come with splenic ruptures because maybe someone had a splenomegaly, and they used to, in Kamba, it's called kuokelia kavo, and it caused a lot of ruptures in that. We'll go to the questions. Drug of choice for anaphylaxis has been asked by Maristela Wamalwa.
The drug of choice for anaphylaxis, we've made a presentation on that. There are 3 drugs, but the most important one is adrenaline. Adrenaline, that's one. And the second one that is important, so adrenaline is for immediate control. The second one is hydrocortisone, which has some intermediate to long-term control. And then there's a periton. The periton keeps the mast cells. You remember the cells that produce it's not a hormone. Is it a hormone? Histamine, Simon?
It's
Histamine
not a hormone, but it's histamine. Yeah.
So when you give periton, it stabilizes those mast cells and they stop producing the histamine, which then makes the situation worse. So the most important medication is adrenaline. Make sure you know the dilution, because there's 1 in 1,000 and 1 in 10,000. So is there an anesthetist in the call who can tell us what's the dilution that we use for anaphylaxis with adrenaline?
You can type in the chat 10 seconds.
In the chat, please. Thank you. Is it 1 in 1,000 or is it 1 in 10,000? Otherwise, that will be your homework.
Yeah, that now we have gone into the realm of difficulties. I can see no one has chatted so far.
That is homework. If somebody checks, let us know. 1 in 10,000, Christina Chola. Thank you. Thank you, Christine. All right, so just to tell you that there's a difference between the one we use for anaphylaxis and the one we use for a cardiac arrest in ACLS, in the advanced cardiac life support. The one is 1 in 1,000, the other one is 1 in 10,000. So thank you, Christina Chola. All right, good. Simon, do you want to pick the other questions and see whether there's anything else we need to address?
So after blasting them, Joshua Juma has asked, we have some patients with very tiny veins. How will we use a green or a gray cannula in such patients?
I have never been unable to put in an IV access, either a minimum of a green on any patient, whether in Kenya or whether in out here in the United Kingdom. So please talk to your anesthetist. There are ways. Why do we always call anesthetists? So it's not just about the anatomy. There are tricks they use to make sure they can see these veins, either by warming the hands or by spraying a substance that may make the veins more vasodilate more, or they know the anatomical regions where you'll never miss a vein. So for me, the quickest way to upset me if I ever come to work on any of the delivery suites is to put a blue or a yellow cannula. Thank you.
What is the right way to give calcium gluconate, bolus or saline?
The last time I checked is a slow IV bolus, over 5 to 10 minutes. I believe
that's
it's
correct. You don't give it as a push. I think slow IV is good.
Yeah, slow IV, and you don't give it as an infusion. It's a slow IV. Thank you.
Can one use epinephrine in the absence of adrenaline for anaphylaxis?
Absolutely, yes, you can. And I mentioned that there are some patients who carry around EpiPens, epinephrine pens, the same way people carry inhalers, people who are prone to allergies. If that's the only life-saving medication you have, please use it. But the essence of having this talk is so that we can ensure we have essential life-saving medication. Again, the systematic review I've just finished, I've looked at 107 papers around Africa on maternal death. And one of the things that I found is the absence of essential commodities and essential medication that is life-saving as a contributor to maternal deaths.
Excellent, excellent. And maybe we can go into the chat and ask how many of you here have access to an AED, automated defibrillator. In 30 seconds, we can take a quick poll. And as Githae has said, we need to tell the governors to buy them before they leave. If you have an AED, say yes. If you don't have, say no. In my place, we don't have, in one of my many places, so no. As Githae, you are seeing our situation, and that points to a big problem.
Yeah, it's very sad. I can see what I will expect, because I'll be reaching out to you guys to do a primary study on the actual situation on the ground. And it's unfortunate. I hope you'll tell me the truth, then I can use that information to make noise on your behalf. But don't wait for me. I think, I don't know. How hard is it, Simon, to make noise about some of these essential equipment?
So for me, having been in the scene for some time now and having been on both sides, both in the private sector, where we are literally forced to undergo those trainings and learn the AED, on the public sector, because this is not a requirement. And that's the reason some of these things are actually missing, and majority of people here may be in the public sector. So the second question may be, how many have in the last 1 year or 2 years done a course in BLS or ACLS? That might inform now the need to actually advocate for AEDs and actually push for a course. How many have done BLS, ACLS in the last, let's put 2 years?
Yeah, as they respond,
that might be the next. Maristella has never done, so that might be in the next course of action for COGS to train everyone on all this.
Yeah,
some
let's
have
start with
did in
basic
2014, 20, yeah. So BLS. So for me, that is the way you push the AED agenda, when people know how to use it. Thank you very much for your responses.
And Simon, make sure you invite the CEC for Health or the governor to these trainings, to open and close them so they understand what they are about. And the other thing is about AEDs. Just to give you an example, you know the telephone booths, the ones that we used to make phone calls before mobile phones. Yeah. So where I am, telephone booths have been turned to places to put AEDs in the community. So you go to the nearest telephone booth, you're going to find an AED there. So if somebody collapses on the street, you'll be doing that before the ambulance is with you within 7 to 8 minutes.
Yeah. So now we take another poll. As Dr. Muriithi has said, when you make a call, the ambulance will be there in 7 to 10 minutes. Now, can you tell us, when you make a call in your place, how fast will the ambulance be there? Or is it there in the first place? I'll just take a quick poll, because these are some of the 2 hours. Kelvin Limo, 2 hours. The ambulance will be there. I'm waiting for other feedback. It comes after 5 hours. Gaspar says, Timothy Kiblagat is in a nice place, 45 minutes. Fabian Keino, 2 hours.
And there's somebody who's corrected us that
ambulance available.
Yeah, for anaphylaxis it's 1 in 1,000, and for cardiac arrest is 1 in 10,000. Somebody's corrected us. I just noted that. Thank you.
Excellent. So we can see the diversity. Majority of the places there'll be no ambulance, and this is why there is need to develop pre-hospital care and community. These are some of the challenges that Dr. Mwebia will be taking up as COGS and working with all other cadres to try to develop the community emergency preparedness and the referral mechanisms. These are some of the suggestions we have made. Yeah. Fantastic. No fuel has been cited as yeah. So that's it. I am not seeing any other question. Does someone else have a question? There are people who have raised their hands. Can I unmute them? Saudia. Okay, I think, I don't know why they are raising their hands.
I have a point to raise. Can Lucy, Fozia, Agnes?
Yeah. Do they want to speak?
Can try and mute yourselves if you want to speak. Yes, Agnes. Dr. Simon, I don't think.
With that, I want to thank Dr. Muriithi for that very succinct presentation on maternal collapse. And I think the topic can be very wide, but he has simplified it and enabled us to be able to have a systematic way of approaching and have sources to guidelines where we can download and put them in our units. As you can see, Dr. Githae, there is a lot of work to be done, and there is so much education that we require to improve our health systems. And with that, I would like to inform everyone that this presentation will be available by tomorrow evening on the Kenya Obstetrics and Gynaecological Society YouTube page. I think this is far much easier for you to sambaza to all the other people who may not have been present at the presentation. And you can subscribe and follow all the other presentations that we have done. And on Wednesday, we'll be having, I suppose, neonatal resuscitation, which I had to do today. So I think it will be useful again on Wednesday at 7:30. And Anthony Mwangi, I've seen you again. I've said YouTube, Kenya Obstetrics and Gynaecological Society page. CPD points will be sent to the email addresses you have registered with. And with that, I think we can bring the meeting to a close. We like to keep the meeting short and sweet so that people don't fall out by the wayside. But we are very encouraged by the participation. Our initial trainings had 40 people. Now we are reaching in the ranges of 300 and above, showing that there is need for COGS to work with all other cadres to do the training to improve maternal health. And with that, unless someone else has anything to say, I would like to bring the meeting to a close.
So much, Dr. Simon, and thank you, Dr. Muriithi, for spending time for us. Thank you so much, everyone, for attending today's session. We'll meet you all on Wednesday. Have a good night.
Thank you and good night.
Thanks, everyone. Bye.